Welcome to the Peds Hub podcast. We are a group of paediatric trainees in the Southwest who every month review a selection of articles that we find useful for our practice.
These are taken from the BMJ, Archives of Disease in Childhood Journals.
For the full articles, please go to their website, journals.bmj.com. Please note, these are our own opinions and are produced for educational purposes only. They are not intended to substitute professional medical advice, diagnosis, or treatment.
Thanks for listening.
Hi, my name is Paulina Connolly. I'm a specialty paediatric registrar currently working in Southmead NICU, and I'm joined today by Hannah Salis, a lecturer in psychiatric epidemiology with a master's in medical statistics.
Hello.
Hannah is very kindly going to give us her take on the statistics and study designs used in this paper. So this month, we've chosen to talk through the article in Archives Fetal and Neonatal May edition, Antenatal Corticosteroids and Neurodevelopmental Outcomes in Late Preterm Births by Dr. Amir Aviram et al., an obstetrician in Toronto. This article caught my eye this month, as the obstetric team asked us last week to come and discuss steroids with a mother who was 34+1, and quite specifically wanted to know about the potential risk of neurodevelopmental disorders. We're not typically asked to counsel about steroids, as the parents usually talk about them with the obstetric team, so this caught us off guard. We're all aware of the benefits, but what are the risks? So a quick recap on antenatal steroids. The Royal College of Obstetrics and Gynecology guidelines advise steroids to be administered to all mothers who are expected to deliver between 24 weeks and 34+6 in the 7 days prior to expected delivery. The optimal benefits are conferred if the first dose is given 48 hours prior to birth, but are also seen if it's given within 24 hours of birth. The evidence for this is pretty solid, and studies have shown a small but significant reduction in perinatal mortality and neonatal death, intraventricular hemorrhage, respiratory distress, and developmental delay in childhood. The evidence suggests, however, that if the steroids are given more than 48 hours, but less than 7 days before delivery, the only benefit that is still conferred is a reduction in respiratory morbidity. Once you go beyond the 7 days, there are no likely benefits, and in fact, the steroids may lead to a lower birth weight, particularly with repeated courses. The guidelines also discuss giving mothers the option of having steroids in the case of planned C-sections between 37 and 38+6 weeks. They advise clinicians to discuss the possible benefits of reduced respiratory symptoms versus the possibility of neonatal hypoglycemia and possible developmental delay. The evidence behind giving steroids was not the strongest, hence only suggesting that they may be helpful. However, the RCOG guidelines make no recommendations on the late preterms, 35 weeks to 36+6, as there is insufficient evidence to support the administration in this age group. The studies that have been conducted did show a reduction in the need for respiratory support, but also showed an increased risk of neonatal hypoglycemia, with a lower number needed to harm than benefit, i.e. you needed to treat 33 mothers with steroids for one baby to avoid respiratory support, but only needed to treat 11 to cause one baby to have neonatal hypoglycemia. These guidelines allude to potential increased psychiatric and behavioural diagnoses if born at term, but state that there is a lack of large-scale observational studies to be certain. In the studies that are out there, there wasn't a control group that received no steroids, just one course versus lots of courses, but they do link repeated courses to increased rates of neurodevelopmental concerns. Animal studies also suggest cause for concern and have shown that steroid exposure is associated with delayed brain maturation and alterations in the hypothalamic pituitary adrenal axis. This same author, Dr. Aviram, had previously looked at neonates born at term who had received steroids at some stage in the pregnancy and noted an increased rate of healthcare utilisation for possible sensory and cognitive disorders. Whilst most hospitals don't administer steroids to term mothers, many will have complications earlier in the pregnancy, resulting in precautionary administration of steroids, to try not to miss that narrow window of benefit to the preterm if they do deliver. But what are the impacts on the late preterm group, where there may arguably be slightly more of a benefit in reduced respiratory morbidity? What is the impact on their neurocognitive development? And so to this paper. Let's look at the methods. The authors carried out a population-based retrospective cohort study to look at the impact of steroids administered before birth in babies that were born between 34 to 36 plus 6 weeks. They managed to capture a huge number of babies thanks to the Ontario database systems. All babies born in a hospital are documented in the Better Outcomes Registry and Network, or Born Ontario. Their exclusion criteria were multiple births, major abnormalities or genetic problems, intrapartum asphyxia, although they didn't specify what their criteria for this was, and any babies with insufficient information available. Follow-up was through another set of healthcare administrative databases, which captured all healthcare utilisation via their insurance claims. We'll come back to this in our limitations. The exposure group was antenatal corticosteroid exposure before 34 weeks, again using maternal records on the Born database. The documentation is slightly flawed, however, as we only know that they were or weren't given, not when, how much, or which steroid. The authors are confident, however, that most will have been given a standard dose according to their Royal College guideline. The children were followed up until 5 years of age, and the outcomes were formulated around the available information. Rather than diagnoses, the authors had to look out for service claims only, so the outcomes were listed as 1. Suspected neurocognitive disorder, 2. Audiometry testing, and 3. Visual testing. Right, let's look at the results. Firstly, the study population. So within the timeframe analysed, 738,377 babies were born. Once they removed all those who fit the exclusion criteria, they were left with 2,689 babies who were exposed to steroids, which make up 10.5% of the group, and 22,979 babies who hadn't been exposed, 89.5%. When comparing the characteristics of the study versus the control group, a few things were statistically significantly different about the groups, as you might expect from an observational study. The mothers who received steroids tended to be older, with a larger number over 35 years of age. But whilst this was statistically significant, we're actually only talking 19.5% versus 17.8%, so actually hardly a big difference, particularly when you take into account the smaller sample size in the exposed group. They were slightly more likely to have had a previous child and had a higher rate of C-sections. Comparing the baby characteristics, somewhat surprisingly, babies who'd been exposed to steroids were more likely to be resuscitated, 32% versus 26%, and admitted to NICU, 34% versus 20%. Less surprisingly, given the previous data, the steroid group had more babies born with a weight lower than the 10th centile, although there were not significantly more mothers with hypertensive issues in this group. Interestingly, the unexposed steroid group were more likely to have had preterm premature rupture of membranes, which I suppose makes sense if they were worried about a risk of infection. Moving on then to the analysis of the results. They did 2 analyses, one unadjusted and one adjusting for potential confounders using the Cox proportional hazards analysis. Confounders included maternal age, week of gestation, birth weight less than 10th centile, 5-minute APGAR less than 7, resuscitation at birth and admission to NICU, as well as maternal and delivery variables. Hannah, would you mind explaining the graphs that they've used?
Yeah, sure. So the authors used a Kaplan-Meier curve to show the cumulative likelihoods of the study outcomes and compared these using a Cox proportional hazards model. So Kaplan-Meier curves plot the survival probability on the y-axis against the timeline on the x-axis. The line starts at the top of the y-axis at 1, and then every time an event occurs, in this case a healthcare assessment, the line gets lower.
Brilliant, thanks Hannah. So then looking at the 3 outcomes, there were more healthcare assessments in the exposed group in all 3 outcomes. When analysed at a fixed time point of 5 years, both neurocognitive and audiometry testing was statistically significantly higher in the exposed group, but there was no difference in visual testing. Neurocognitive assessments were seen in 43% of exposed children versus 37.3% in the unexposed group, and audiometry testing in 23.3% of the exposed group versus 19.8%. When they looked at the adjusted ratios, same story here. They noted a greater risk of testing for suspected neurocognitive disorders, AHR of 1.12, and audiometry testing, AHR of 1.2, in the exposed group, and a slightly higher risk in visual testing, AHR of 1.06. So Hannah, what did you think of the statistical methods used in this paper?
So I thought the methods all seemed fine, so this is a pretty standard approach for the study design. I thought it was really good, though, that they identified their confounders a priori. So this means before starting their analysis, and it means that it's theory-driven rather than being driven by the data.
Okay, good to know. Moving on then to the discussion and conclusions. The authors concluded that antenatal corticosteroids resulted in a greater probability of requiring an assessment for a neurocognitive disorder, audiometry testing, and visual testing compared to the control group. Their results are in line with a recent population-based study in Finland, though this study didn't look at the late preterm period specifically. Reading through the paper, I agree that there is some evidence here to warrant further investigation, but that, whilst the sample size was large, that there are quite a lot of limitations which the authors themselves note. And some of these are general limitations with retrospective cohort studies, aren't they, Hannah?
Yeah, absolutely. So while retrospective cohort studies do have a lot of advantages, so for example, they're much more efficient than a prospective cohort study, where we have to recruit our sample and follow them up over time. In a retrospective cohort study, the researchers identify a sample, so in this case using the Born database, and look back in time at existing data. So, however, there are some important limitations to bear in mind. So if we were conducting a prospective cohort study, we would decide exactly what data we're interested in and collect that from each of our participants. In a retrospective cohort study, we're limited to the data that's already been collected.
So, like the lack of data around the steroid administration. When was it given? Was it shortly before the birth or weeks before?
Yeah, exactly. However, one positive with the fact that the study uses existing medical records means that the study is unlikely to be subject to recall bias. So recall bias occurs when we're relying on participants' memory of events in the past. So these may become inaccurate over time and can be influenced by later events and experiences. So this isn't going to be an issue here.
Okay, brilliant. And were there any other limitations?
So there's confounding by indication. So this is where we have potential factors that are indicated by our exposure. So any association we see may actually be between the indicator and our outcome, rather than between the exposure and our outcome.
So in this case, are you talking about the indication around the steroids?
Yeah, that's right.
So, as the authors pointed out, they were unable to tease out whether or not there were any confounders that they couldn't adjust for, like the tocolytics, which would likely have been given to many of these mothers. And similarly, they were unable to rule out that the indication for the steroids, e.g. preterm labour, in the first place may be the cause of the poorer outcomes. We also have limited data regarding the rest of the neonatal course, although in the adjusted analysis they did remove all babies who'd been admitted to NICU, and that made no difference to the statistically significant results. But there's no data regarding, for example, neonatal infections and treatment for suspected infection or hypoglycemia. And all of these issues in the UK would often be treated without admission to the NICU. So then there's the lack of diagnoses. The authors felt that parental concern resulting in health-seeking behaviours was good enough substitute for actual diagnoses. That can be argued both ways, but personally I would prefer to see the outcome of those assessments. Another question that I find interesting, but that's slightly outside the scope of this paper, is there a time frame within which administration of steroids is most detrimental? At this stage, this is fairly academic, given we are unable to 100% predict whether or not a baby will have to be delivered within a specified time frame, but would be interesting to know. So, will this paper change my practice? Well, I'm much more informed now regarding the potential neurocognitive outcomes, but I think all I can really say to parents is that there may be an association. As always, we could really do with a large randomised control trial to get some solid evidence. And in the particular case of the 34-weeker I mentioned, the mother opted for the steroids and the baby was born in good condition and did not have any respiratory distress or hypoglycemia after birth. So all ended well. As always, thank you for listening. And Hannah, thank you so much for your input on the podcast today. It's been really helpful.
No problem. Thank you for having me.
And listeners, if you have any feedback, we would love to hear from you. See you next time.
Hello again, I'm Bex, and I'm an ST3 working in the 7 Deanery, and I'm the Education Fellow for the South West. I've picked an article entitled 15-Minute Consultation, Recognition of Sickle Cell Crises in the Paediatric Emergency Department, and it's by Shrina Patel and colleagues based in Swansea and Cardiff. It's taken from June's Archives of Disease in Childhood, Education and Practice. I thought this article would be interesting to discuss, as I quite like acute medicine, but my experience of caring for children with sickle cell disease is really lacking. So I thought it'd be good to refresh mine and maybe your memory, as one thing I've gleaned from reading this article is the quick identification of complications and management can save these children's lives. First off, a little bit of background and a bit of a refresher on sickle cell. This is taken from the Sickle Cell Society website. 1 in 79 babies born in the UK carry the sickle cell trait, and around 15,000 people in the UK have sickle cell disorder. Sickle cell disease is screened for in the newborn blood spot, and the test can be offered to some women during early pregnancy. I know from one of the regional teaching talks from the haemoglobinopathy fellow, there's around 90 people with a sickling disorder in the southwest. Incidence in the UK is increasing, and there are more acute admissions every year for this disease. It is particularly common in people who are of African, especially West African and Caribbean descent, but also Middle Eastern, Indian and Mediterranean. And as you already know, it's an autosomal recessive genetic trait caused by a mutation in the beta globin gene. As a fetus, our hemoglobin is made up of 2 alpha and 2 gamma globin chains, and about the age of 6 months, the production of hemoglobin changes to alpha and beta, and hence this is often when the symptoms start to present. The hemoglobin S produced by the mutated allele will polymerise, and it distorts the shape of the red blood cell when deoxygenated, or in the presence of acidosis, or when there are, for example, extremes of temperature or dehydration. This polymerisation causes the red blood cells to sickle, and this impacts the red blood cell's lifespan, and it causes a hemolytic anemia, as well as the possibility of blocking vessels too. So the article talks about how children with sickle cell could present to the emergency department. The scenarios demonstrate different sickle cell crises, and I think a useful way to categorise these would be visceral, aplastic, hemolytic and painful. And often these can be precipitated by hypoxia, infection, dehydration, extremes in temperature and drugs. So the article starts by giving some general principles about how to manage a child who attends the ED. So number 1 is to listen to the parents and to the patient. The parents are the patient's best advocates and they're experts in their child's care. Number 2 is every child with sickle cell should have their own individualised care plan, and it should be read, printed and followed at each presentation. Number 3, give oxygen, specifically aiming SATs of greater or equal to 95% or within 3 of whatever their baseline is. Number 4 is to give adequate analgesia. 5 is to focus on rehydration, which would include fluid resuscitation and adequate ongoing hydration, depending on what the child looks like. 6, investigations. So that is your blood tests, and they make a list of recommendations, including a full blood count, reticulocyte count and a blood film, group and save and a cross match if you need it, urea and electrolytes, liver function tests, a CRP and a blood gas. And with this, you want to find out what's the child's usual HB and compare it to what you've found out now. And then number 7 is speak to the tertiary specialist team. So in our case, that would be the paediatric haematology team at the Bristol Children's. So I'm going to go through the cases, but slightly adapt them or summarise them so as to not plagiarise. So the first case, this is a young boy who'd been out in cold weather earlier that day and now complains of severe pain in his arm. There's nothing else in the history or examination, so there's no history of trauma. And he's tried regular over-the-counter analgesia at home with no effect. This boy is suffering from ischemia to his arm because of a vaso-occlusive episode or crisis. And this is giving him that acute painful crisis that I talked about earlier. It is the most common complication and reason for attendance to the emergency department. And in the history, the clue here is the exposure to the cold, as this can often be a trigger. So let's go back to our generalised principles, and we can review the NICE guidance for sickle cell disease as well, which focuses on managing acute painful episodes. So number 1, we're going to listen to the parents and the patient again. They often know what analgesia they need, what they've had before, and if anything's different about this episode. Number 2 is to follow the care plan. 3, we will skip this one for now, I think, so that's about giving oxygen. Again, the care plan should tell you what their target saturations are, so have an awareness of what they should be and what the child's are in front of you. 4 is give adequate analgesia. So use the Wong-Baker faces or get them to rate it out of 10, something age appropriate. Make sure you're giving that regular over the counter, so paracetamol, ibuprofen, but then we're going to give bolus of a strong opioid medication. You'll need to consider the administration route, and that's going to depend on what access the child has and what you can get. And if it's difficult, then think about things like intranasal fentanyl, oral morphine to start with. We're going to really frequently reassess, so every 30 minutes until the pain gets under control, and then 4 hourly after that. And you might even have to consider sort of PCA if we're needing repeated boluses. Remember that opioids can cause respiratory depression, so these children need really close monitoring, and they're going to need comfort measures as well, things like laxatives and antiemetics. 5, rehydration if that's necessary, and strict input and output monitoring. 6 is those investigations we talked about earlier. And then 7 is speak to the haematology team. And I'm going to add in here, have a low threshold for involving the orthopaedic team. And that's because there's a number of differentials to this case that we need to think about. So I'm thinking osteomyelitis and avascular necrosis of the hip, but then other things could be an acute stroke, aplastic crisis, infection, splenic sequestration, or acute chest syndrome. The second case is a young child who presents with breathlessness and chest pain. On observation, they have a low-grade temperature and increased work of breathing. Now, this could just be a chest infection, so, we're in a pandemic, or maybe an asthma attack if there's a past medical history of asthma. But in this case, they have acute chest syndrome, which is the leading cause of mortality in patients with sickle cell disease in the UK. And so any child with this suspected condition must be seen in hospital. The diagnosis is made based on chest x-ray changes, so they get infiltrates, plus respiratory symptoms and a fever. There are lots of different causes again, not just infection. So an example is an vaso-occlusive, atelectasis and fat embolism. Hemoglobin levels can drop really quickly and that can lead to an oxygen requirement. And the mainstay of treatment is to maintain the oxygen saturations, give broad spectrum antibiotics, give analgesia, and intravenous fluids if necessary. Interestingly, this article also talks a little bit about the impact of COVID on the health of children with sickle cell disease. The respiratory illness is quite low risk. However, there is more of an issue if these children develop PIMS-TS, as they require high-dose steroids to stop the inflammatory disorder, and actually steroids have a negative impact on sickle cell disease. So once again, you're going to speak to your friendly paediatric haematologist for advice. The next few cases I will summarise a little bit more briefly. So case 3 had an ischemic stroke. They presented with unilateral weakness. In the history, the patient had recently completed some high-intensity exercise and was dehydrated. And of note, so part of the yearly review that children have with sickle cell, they should have a transcranial Doppler to monitor for stenosis. And again, so it's always worth having a look at their letters to see if they were high risk for a stroke in the first place. But irrespective of their risk, if you suspect the child clinically has had a stroke, then they require urgent imaging within 1 hour of arrival to the emergency department. It's very rare that children with sickle cell disease need thrombolysis. The treatment, irrespective of bleed or infarction in patients with sickle cell, is to urgently lower the amount of sickle cell hemoglobin in the blood whilst preventing anemia, so they need an exchange transfusion. If that's not available, then the second best thing is transfusion, so that is another option, but that should be discussed with the haematology team before starting. We would also need to enact neuroprotective measures, so with regards to oxygenation and carbon dioxide, and trying to prevent any rise in intracranial pressure. Finally, I think with this case, and with all the others I'm going to talk about in this podcast, being aware of your location and the setting that you're in is important. Is a district general hospital the most appropriate place for this child to be in? And should I be contacting Watch in case we need to urgently transport them to a tertiary centre? Or in case my child begins to deteriorate and I need advice? So with all these cases, early discussion with Watch is advised. Case 4 presents with abdominal pain and is found to have splenic sequestration. This occurs when the sickle-shaped red blood cells, they get trapped in the veins of the spleen and they obstruct drainage. Blood pools there and that leads to splenomegaly. And so typically the patient is a younger child, they present with splenomegaly and signs of hypovolemic shock. They require urgent fluid resuscitation, and on discussion with the haematology team, they may suggest a blood transfusion. I think if you are ever thinking of transfusing a child with sickle cell disease and they are stable enough that you have time to call the consultant haematologist, do that. Because transfusing a child with sickle cell with blood can put them at risk of hyperviscosity, so it's just not without its own risks. Another thing to consider in children with splenic sequestration is that functionally they may have asplenia, and so they're at risk of infection with encapsulated organisms such as Streptococcus pneumonia, Haemophilus influenza, and Neisseria meningitis. So if they're febrile, take cultures and start antibiotics. If a child with sickle cell disease requires a blood transfusion, then we should notify the blood bank of their condition. And if there's time, we should ask for the blood to be ABO compatible, extended resus and KEL matched, or if there's no time, just ask for best matched blood. The final case I'm going to discuss is a little girl who presents with a recent febrile cold-like illness and now has redness to her cheeks, which look like they have been slapped. She's also noted to look clinically anemic. So you guessed it, she's got parvovirus B19, which in children with sickle cell disease can cause bone marrow suppression and therefore an aplastic crisis. The treatment for this again is blood transfusions, and the bone marrow should recover within 2 to 3 weeks. But finally, I do want to mention a rare but life-threatening complication that I had not heard of, which is fat embolism syndrome. It's a complication of parvovirus and it can cause bone marrow infarcts, and these children will present with an array of symptoms, including things like petechial rash, neurological and respiratory deficits, and the treatment again is a red cell transfusion. So to conclude, we clinicians need a really good understanding of the complications of sickle cell disease because early identification and management can save their lives. I think particularly in the southwest, as cases are a little rarer, it's always worth refreshing your memory on this. Sickle cell is the most common inherited hemoglobinopathy in the UK, and case presentations to the ED are consistently on the rise. So this is something we are only going to see more of in the future. So that's your lot today. Peds Hub has got some really great lectures on hemoglobinopathies by Dr. Regina Nolan and Dr. Dan Jolly in previous regional teaching day sections, so it's well worth checking those out as well. Thanks for listening. Bye.
That's all for this episode. As always, if you have any questions or comments, please feel free to get in touch via our email address podcast@pedshub.co.uk or via the Peds Hub website. Equally, if you'd like to get involved, we always welcome your voices, so please do get in touch.
Thanks for listening.